respected chairpersons, distinguished guests, esteemed delegates from Nepal and around the globe. Namaste and a very warm welcome to the most awaited event of our professional calendar. It's SHANCON 25, the International Conference of Speech and Hearing Association of Nepal at the Grand Norling Hotel on this beautiful morning. I am Sabin Sharma, speech language pathologist, the master of ceremony for this SHANCON 25. It's my privilege to stand before you as we officially open this landmark event under the inspiring theme, Empowering Individuals with Communication Disorders, a Multidisciplinary Approach. We'll share knowledge, exchange innovations, and most importantly, renew our shared commitments to every voice that deserves to be heard and every swallow that deserves to be safe. Let us begin with energy, respect, and the spirit of true collaboration. So now we begin our scientific session. We have a keynote session at first. For that, now I'd like to open the first keynote speech session of SHANCON 25. I'd like to introduce and welcome our chairpersons of the session and request to kindly chair the keynote session. Firstly, I'd like to introduce Professor Dr. Rakesh Prasad Srivastava, MS, FRCS. Prof. Rakesh is the chairman of Impact Nepal and a trustee of the Nepal Care Foundation, as well as esteemed academician of the Royal Nepal Academy of Science and Technology, a former dean and the head of the Department of ENT at NS Institute of Medicine, has authored several textbooks and several scientific papers. In 2002, he pioneered cochlear implant surgery in Nepal. So we'd ask you to chair the session, sir. Also, I'd like to request Mr. Kaviraj Khanal to chair the session. Mr. Kaviraj Khanal is the Technical Director, Hearing and Speech, and Chief of Audiology and Speech Language Pathology Unit at the Trivandrum University Teaching Hospital, Nepal, with over 30 years of experience in clinical audiology, SLP, and rehabilitation. He has significantly contributed in this sector. Mr. Khanal is an advisor to the Speech and Hearing Association of Nepal, a past president of SHAN, and also advisor of Nepal's Doctoring Association. We'll ask you to chair the session. I hand over the session to our respected chairperson and hence request to introduce the keynote speaker and the topic. Thank you, sir.
First of all, I'd like to introduce Professor Sanjay Kumar. He is professor in charge Speech and Hearing Unit, Department of ENT, PGIMER, Chandigarh. Before I introduce him, Professor Munjal in general is a very known and a leading figure in India in the field of speech and audiology. Professor Munjal is a leading expert in audiology and speech language pathology with over 30 years of clinical and academic experience. His work spans auditory electrophysiology, cochlear implants, tinnitus, cleft lip, and voice disorders. He has published 86 research papers, authored 4 book chapters, and presented at 75 national and international conferences. A recipient of multiple prestigious awards, Professor Munjal is also a life member of key professional bodies and serves as an advisor to universities across India and Nepal. Welcome, Professor Munjal.
We all know that these cochlear implants, they are the highly advanced medical devices, which have revolutionized the way in which the hearing care is taking place or is progressing. So this also we know that it has 2 components. One is the external component, which is worn outside, the internal component, which is implanted with the surgery. Now, when it comes to who are the candidates for the cochlear implantation, so the FDA has been the main authority which plays a crucial role in regulating these devices. It comes up with approval process that what would be the candidates, who are the candidates. So we'll go through how this criteria has emerged over a period of time. It all started with the 1985 when the post-legally defined more than 80 years of age were considered as the candidates for the cochlear implantation. Then in 98 this criteria expanded to see when to profound degree of hearing loss with speech perception score of less than 40% in the breast treated condition. So in 2000, the speech perception scores were decreased to less than 50% in the year to be implanted and less than 60% in the breast treated year. Then in 2014, we had what is called as the hybrid or the electroacoustic system, so which was given to the subjects who had low frequencies were preserved and high frequencies had moderate to profound degree of hearing loss. Then the single-sided deafness and the acquired hearing loss less than 10 years of age deafness. So those were the the clinical conditions where the approval was provided for these. And then of course after that there has not been any major change in the criteria as far as adult CI is concerned. Coming to the pediatric population, 85 it was not approved for children. Started in 1990 when the approval was given for 2 years and older children with a profound degree of hearing loss. Then the age criteria was reduced to 18 months and then then to 12 months, then expanded to severe to profound degree for those 2 years and older. 2014 as such not major change has occurred, but in 2019 again addition of single-sided deafness and age-restricted hearing loss for ages 5 plus with less than 10 years of deafness. And then this criteria in 2020 was changed to 9 months. So this is how the candidacy criteria has evolved over a period of time. And why these guidelines have been expanded or has been changing, it is because of the data which we get when these patients who have been implanted and the technology which is changing so fast with the change in the electrode design, the technology, we have now multi-channel implants and the speech processing strategies have become better. Because of that, the criteria has been changing consistently and it is new criteria are evolving, but still in spite of this gradual expansion in candidacy, there is still a significant underutilization of the very effective technology. So we need to, I'll be discussing some of the, conditions where in spite of, the FDA has not approved it, but we are still doing what is called as the off-label candidacy criteria. So this is, and this criteria is, if you look at the global scenario, the criteria varies from place to place. In certain countries, we have their own regulations, so there is as such no universalization as far as the CI candidacy criteria is concerned. So, coming to the pediatric cochlear implantation, let's see what are the conditions where the off-label CI candidacy has been there. Now, like the FDA has approved the implantation age of 9 months. Okay, but there is abundant evidence to support better outcomes in infants as young as 6 months of age. And then especially in cases like bacterial meningitis, where there could be the evidence of imaging evidence of fibrosis and ossification, the CI should be done as early as possible. Then the age criteria does not come into the consideration, because otherwise ossification would occur and it becomes very difficult to implant such children. So the criteria is evolving where the younger and younger infants are being, as young as 6 months of age are also being implanted. This is one of the study which shows that when these children who are implanted early, before the 9 months of age, they catch up with normal hearing care much earlier as compared to those infants or children who have been implanted later in life. Similarly, those with residual hearing. Now, till date, we have been doing cases, adult population with residual hearing, but then again, the data is emerging where the children with residual hearing are also being considered as candidates for the cochlear implantation, because they they have better speech perception in noise with cochlear implantation. They have better appreciation of music. Okay, so now the criteria is emerging where these children are also being implanted with residual hearing. Now this is one of the study where the authors have followed up these children with significant residual hearing, and it has been seen that there is significant difference in their scores pre and post implantation. So on a case-to-case basis, we have to see whether the child is getting benefit with the hearing aid when he has some residual hearing. If he is not, then it should be considered as a candidate for cochlear implantation. So the cochlear implantation should not be restricted only to those with severe to profound degree of hearing loss even in children. Then we all know what are the benefits of the the binaural hearing in terms of sound localization, the head shadow effect, binaural summation, and binaural squelch. And in binaural, again, we have two options, that is the bilateral and the bimodal. And in bilateral, we have sequential as well as simultaneous. Now we started with unilateral cochlear implant that switched to the bimodal. Now bilateral has more or less become a norm, and in binaural also there are earlier we started with sequential. Now it is the criteria is evolving where we are now. It has become almost a norm to do simultaneous cochlear implantation, that is in one sitting do both implants in both ears. And again, there is lot of data to suggest that those who have simultaneous bilateral cochlear implantation, they do much better than those who go for the sequential. And of course, the bilateral is always better than unilateral. Again, a lot of data is there which shows that their localization abilities, their speech in noise scores are much better when the children are implanted bilaterally, and that too when there is a significant difference in these scores when you compare between the sequential and the simultaneous implantation. Then the other condition is the single-sided deafness. Single-sided deafness is again was a condition which some time ago was not considered as a candidate for cochlear implantation, especially in children. Again, we have a lot of data to show that their speech in noise scores, their word recognition scores are much better when the other ear is implanted. Even one ear is normal still. So I think we need to extend the criteria to single-sided deafness, where one ear is normal and other ear has severe to profound degree of hearing loss, where there is no benefit with the or significant benefit with the hearing aid. Then there are conditions like intellectual disabilities, learning disabilities, developmental delay. All these are the conditions which were not being considered as candidates for cochlear implantation. Now, there's a lot of data to show that these children also get benefit with the hearing aid, though their benefit may not be same as of the typically developing children. But these are the this group of children where we should not be deprived of cochlear implantation, and the now criteria is evolving to implant these children. Only thing is that they should be fit for a surgery. Then the cases of like cochlear nerve aplasia, there is there's doubt about the functioning of the cochlear nerve, but the evidence suggests that these children again they have speech recognition abilities at least in close set, and now the latest trend is that we test the stimulability of the auditory nerve with the help of what is called as transtympanic AVR. So it is a technique where we place the electrode near the promontory. It is done intraoperatively, and when there are responses, if you see the AVR waveform, so that means the nerve is stimulable. I think Professor Ajit will be discussing this I think tomorrow in his presentation. So that is now the technique which has evolved over a period of time, that whenever there is a case of cochlear nerve aplasia or thin nerve, so do transtympanic AVR. If the responses are there, take them as a candidate for cochlear implantation. There is another technique which has come up, which is called as auditory nerve test system (ANTS). Here the electrode is placed in the cochlea itself intraoperatively, and the responses are present. So then again, they are considered. Here you can see this is one case we did last week only, and where we tried this ANTS test for the first time in our institute, and we could get very good waveform on the table. So whereas the transtympanic AVR did not show us anything. Okay. So in that setting itself, we went ahead with the cochlear implantation. Of course, that was a case of the auditory neuropathic spectrum disorder. But now the latest trend is that any case where there is a doubt whether the auditory nerve is stimulable or not, go for TTAVR, and there is no response, can go ahead with the ANT system, and if there is a response, go ahead with the cochlear implantation. Then, of course, there are other cochlear anomalies like the inner ear dysplasia and Mondani dysplasia. So again, these are the candidates which were earlier not considered as candidates for the cochlear implantation, but now the criteria is evolving that where these children with these deformities are also being implanted. And this is one of the study done by Dr. Manish Grover, where they have shown that these children who have different anomalies of the cochlear vestibular system, they their scores are improving over a period of time. So that means they are also getting benefit with the hearing aid, with the cochlear implantation. Then we know that auditory neuropathic spectrum disorder is again a heterogeneous disorder where we are always in a dilemma whether to go for the cochlear implantation or not, because some of the children do well with the hearing aid, others do not do well, or some children do very well with the cochlear implantation, others do not do very well. So now, as I discussed, that this ANT system or the transtympanic system should be used to see the candidacy in auditory neuropathic spectrum disorder where there is no significant improvement with other amplification devices. So, and now these children are again being considered for cochlear implantation, and those who have already been implanted also, many of them have good improvement with the cochlear implantation. This is one of the study where they have compared the outcomes of ANSD 75 patients, and they found that their CAP score and the SIR scores were there was a significant difference in pre and post implantation. So again, this is again an evidence to show that yes, children with ANSD also are candidates for the cochlear implantation, and they should be considered for cochlear implantation. Then those with cognitive or developmental delay, again, earlier it was considered as a contraindication for CI. Now, these children again, they may not have very good speech and language abilities, and they may not be at par. But there are reports where the families have reported that they have now broadened communication skills, they have improved interaction and less family stress. Okay, so this is again one group which is now the criteria is evolving where these children are also being implanted. Coming to the adult CI, this is the criteria that if the hearing loss falls within this, they are definitely considered for implantation, and then this is the area we do not consider them as. So, but there are certain conditions. Let's see what are those. We know that the our criteria is that we assess the speech discrimination score. Okay, and we usually use a criteria of 60. It means if the speech discrimination score is less than 60%, then we will go ahead with the cochlear implantation. But most of these scores are achieved in speech in quiet. Okay, whereas our environment is not quiet; it is noisy most of the time. Okay, so we need to evaluate or need to have protocols to incorporate our speech in noise. Okay, so so because that actually depicts the real day-to-day difficulty which these individuals will have. Okay, and then we take their scores and then consider them as candidates, whether they are candidates for cochlear implantation or not. Okay, now the trend is going towards measuring their speech discrimination scores in noise as compared to in quiet earlier. Okay. So and now we are earlier the speech discrimination scores were being evaluated using sentences. Now we have come to the stage where we need to measure their scores in using the monosyllabic words because they are more difficult to recognize. Okay. Once we put these, get these scores, and those who have poor scores, they can be considered as candidates for the cochlear implantation, rather than those where we use speech, where we use sentences, because sentences again as such, because there's a lot of redundancy in the sentences, and in spite of patients' poor speech perception, the scores actually measured through sentences do not depict their real difficulty. So the trend now, the criteria is changing, where though we are now assessing their speech discrimination scores in noisy environment plus using the monosyllables. Then the electroacoustic stimulation, where the individuals who have the low frequency preserved and the severe to profound degree of hearing loss in high frequencies. Again, these were the candidates who have been traditionally put on the hearing aids using various technology in hearing aids like the frequency transposition, but still they find it difficult to carry on conversation in noisy environment. Okay. So now the trend is going towards the hybrid implant, where we have now short electrodes where the basal end of the cochlea is stimulated stimulated through the cochlear implant, and the low frequencies through the hearing aid. So that is the hybrid system. So this again is criteria is evolving to assess them, and then go for ES whenever possible, especially in sloping degree of hearing loss, where high frequencies have severe to profound degree of hearing loss and low frequencies up to moderate degree of hearing loss. Now coming to the sequential implantation, in adults, the trend has been to put one implant, okay, and then that was traditionally what has been done till date. Now the criteria is evolving, when if the other ear also has hearing loss, so we are giving the bimodal, in the sense that the hearing aid was given to the other ear. Okay. Now sequential implantation is being done. That especially when there is a progressive hearing loss, other ear becomes unedible after some times, and should be going for sequential implantation. And there is a lot of data to show that the results are better. But as and when possible, we should be going for simultaneous rather than sequential. Again, this is one data which shows that they have better speech discrimination scores when they are implanted in simultaneous condition. The scores are much better over a period of time as compared to the sequential one. Again, single-sided deafness has been given approval in 2019 for adults, but still, we as clinicians do not opt for or do not provide that solution to the patient, and we go for conditions like contralateral routing of signals, okay, so which does not provide a true binaural hearing. Okay. So, and even in conditions like when there is debilitating tinnitus. Okay. So there are reports to show that when there is a debilitating tinnitus along with hearing loss, so those should be considered as candidates for cochlear implantation, because in majority of these cases where there is a debilitating tinnitus, the tinnitus improves after the cochlear implantation is single-sided, definitely. So the criteria is emerging where CI is being considered as a treatment option for those with tinnitus along with hearing loss. Now the geriatric population, again this is a population where traditionally they have not been considered as candidates for CI, or there is a reluctance on our part to counsel the patient for cochlear implantation. And because this was a belief that they will perform poorly because of the pathologic, physiological, physical and cognitive factors. They have limited population for stimulation, and they have degeneration in the peripheral auditory system, which can negatively impact their outcome. But there's a lot of data. I'll quote one of this study where they have implanted patients over the age of 85 years, and they've applied this questionnaire on them, and they found that the questions like, has your everyday life changed after CI? Majority of them have reported yes, it has changed. And then how often do you have problems handling your CI? Because that has been always a concern. But majority of the CI users above the age of 85, they have not reported many difficulties in handling these. Similarly, the majority of them have found that their CI has influenced their joy of living. So the data is now there to show that the old age, means age as such, is not a factor when considering the cochlear implantation. Even the patient beyond 85 years of age are also being implanted, and then you are doing well. Only thing is that they should be medically fit. Now then, the other conditions like the advanced otosclerosis with cochlear ossification, round window obliteration, post-traumatic sensorineural hearing loss, as in temporal bone fractures, now even Meniere disease. So these, of course, in the Meniere disease, the device programming can be challenging because there is a fluctuating hearing loss. But these are again some of the conditions where now they are also being implanted, and they all are doing quite well. Now is the era of machine learning and artificial intelligence. So that is also coming up into the in finding out the candidacy for cochlear implantation. This is one of the study where they have tried to find out the sensitivity and specificity of our traditional system of 60/60 and the machine learning, and it has been found that the specificity of the machine learning system has improved to 1, which was 0.42 earlier. So there is this machine learning is going to be coming into deciding or rather assisting in adult cochlear implant candidacy. So to summarize, we have there is a decreased age of implantation, patient with children with residual hearing, single-sided deafness, cochlear neoplasia, inner ear malformations, ANSD, all are now being considered as candidates as far as pediatric criteria is concerned. And the emerging criteria for the adult is the residual hearing, the hearing preservation, electroacoustic stimulation, single-sided deafness, and those with vestibular, cochlear or intralimbric schwannomas like the NF2, and those with advanced otosclerosis, post-traumatic hearing loss, and Meniere disease. So now these are the conditions which are now emerging as the candidates for cochlear implantation. So now, of course, expanding candidate is not enough. We need to have early identification, early intervention, intensive speech therapy, and parents and caregivers dedication for a successful cochlear implant program. So to conclude, the last 1 decade has seen lot of changes because of the improved, technology, the remarkable improvement of the performance of the cochlear implant, and we have now different types and degrees of hearing loss, which can be, can be considered as the conditions where we can implant these children. So the criteria has evolved and is evolving, where more and more, candidates, where more and more patients are being considered as candidates for the cochlear implantation. But yes, a word of caution is that yes, we have to, the candidate selection has to have a high degree of alertness and sensibility, so that we implant only those who need it and do not implant those who do not need it. Thank you, sir.
Thank you very much, sir. Very elaborated presentation about the candidate. Being a speech language pathologist from the beginning, what I want to mention here, the candidate earlier was easy for the speech language pathologist because there was no associated problem. Only hearing loss, that is also profound hearing loss, and parents also very much, their after improvement, fully satisfied. But when the criteria is changed, inclusion criteria is changed, it is very difficult for us. I should not say difficult, but complex. So we have to see all the associated problems also, we have to monitor, and speech language also we have to monitor. And especially earlier only unilateral implant, and they were improving, but now the demand is changed. Like we have already done sequential also, bilateral also, even here also, Nepal also. Then hope the criteria will again change, like a teenagers, coordinators also we are doing the implantation. And in our place also, I think the improvement is good because less number, and we have very less number of the auditive therapists in Nepal. So our job is really crucial, and the parent training, that's also very much important in this auditive therapy, as we know. Sometimes what happens, our parents are not that much educated, and the service available in the country is less decentralized, and some territory also. Thank you very much, sir. Very informative and very good presentation.
Now, I'd like to request our respected chairpersons to hand over the token of appreciation to Professor Munjal. We thank Professor Munjal for his constant support and affection for Nepal. We look forward to his gracious support in our future initiations as well. Mr. Sureshwar Lal Karnan to hand over the certificate of appreciation to our respected chairpersons of this session. It's my honor to invite the chairpersons of these sessions to the stage, who will have the privilege of introducing our esteemed speakers. I'd like to introduce Professor Dr. Vimal Kumar Sinha. Professor Sinha is a pioneering ENT surgeon, former acting dean IOM and former head of department of ENT HNS DUTH Kathmandu, founder and former president of Society of Otolaryngologists of Nepal, as well as former president of SARG ENT Association. He is currently the general secretary of Impact Nepal. So we would like to welcome you as the chair of the session. Also, I would like to introduce Mrs. Sharina Joshi. It's my pleasure to introduce Mrs. Sharina Joshi, who has served with distinction at Trivandrum University Teaching Hospital's Audiology and Speech Language Pathology Unit as one of the pioneering ASLPs of her unit. She completed her BSOP in 2004 and has dedicated her career to advancing clinical practice and professional excellence. I request both of the esteemed delegates to chair the session. Thank you so much. I hand over the session to the respected chairpersons and request to introduce the speaker and the topic. Thank you so much.
And has received multiple national and international honors, including the Lifetime Achievement Award and recognition as the father of speech and hearing of Nepal. Mr. Karna, the floor is yours, please.
Thank you, sir. Good morning. Namaste to everybody. So, today I will be gossiping, not hearing any interesting thing, just thinking on the topic. The condition what we have selected, multidisciplinary approach in order to empower the individuals with communication disorder. What is situation in Nepal? I think you can identify the gentleman. Gentleman. I call myself gentleman. And before going to the topic, I go a little bit to the history. As my boss, Professor Rakesh, I really believes in the history. So I also follow him. How speech therapy was started in Nepal. Here you can see on the left side, the first ENT surgeon of Nepal, late Dr. L. Prasad, Lakshminarayan Prasad, the first generation of ENT surgeon. And not first generation, he is the first one in Nepal. And second generation, his son, who is in front of us. Both of them are ENT. They are the one who had idea to develop the speech and hearing. Me, always interested to study, pursue my career as a doctor, to study MBBS. Tried for several years, but not getting. But I was trying. Once it happened, I applied for BSLP course, which was guided by Professor Rakesh, saying that the course is running in Mysore somewhere. I don't know exactly, but it is in Mysore. That much hint he gave me. And I explored it. That time there was no internet, nothing. But still I explored it. I got the information, I was selected. I applied there, I got selection in Mysore. After 2 days of that, just after 2 days, I got selection letter for the MBBS also. That is to study BSLP course in Mysore was under self-finance, and to study MBBS in King's George Medical College, one of the very renowned medical college in Lucknow. They are under the government's scholarship, India government scholarship. Both not equal. Here scholarship is there happy. Here nobody from own pocket. Very difficult situation. That was a dilemma for me, what to do. And they were my guide. I went to them and they suggested me, they guided me. Then I came out from the dilemma. Now just a little bit I'll tell you what father told, what son told. Father told, no. First year son, no, don't go. Being first person, first year decision of Nepal, how much struggle I have done, I know. I have faced so much challenges. You cannot, you will have same problem, you cannot do it. Forget it. Go study MBBS, have a stethoscope, sit any corner of the country, and present button. No issue. The second generation ENT surgeon who guided me for the speech and hearing, so no. Autonomy. Mr. Khan is a dynamic person. He can face all the challenges. He is the first man in the country. The word he mentioned, first man in the country. That provoked me too much. Then I thought, okay, now no more nothing. I I don't want anything. Without money I can study. I take loan from people. I study. But again, that was helped by both of them to arrange WHO scholarship for me. So I studied there in Mysore, not as a student, simple student, as a king of Nepal. That was the money I was getting. Because of both of them. Now, in the meantime, you can see the gentleman, he's engineer, electronic engineer, and his wife, Claudia Walter. He is Sister Walter and Claudia Walter. Claudia's wife is registered nurse and speech therapist, whereas husband is electronic engineer. Husband was assigned a job in different CPM projects of Nepal. So wife, of course, spouse comes with the husband. She came to Nepal. Husband was busy. And wife was jobless. She wanted to do something voluntarily. And one of the projects for the CPM was one of the blindness project is there, NAWB, whose chairman used to be Dr. L. Prasad. He was the president of that. So Mr. Peter came in contact with Dr. L. Prasad and he introduced himself, his wife also, and he expressed, my wife is a speech therapist. She wants to start a speech therapy in Nepal somewhere. How can you help us? So they are the one who started taking the way. Then these three great people, Dr. Lakshmi Prasad, next one in middle, Professor Ram Chaimana Matya and Professor Rakesh Prasad, they discussed themselves where to start, how we can start. And both of them, these two, were from teaching hospital where I used to work. He was in the government hospital, other biggest hospital of the country. They three discussed and finally they decided yes, speech therapy should be started in teaching hospital. And this, the demand was we should have two ongoing person, the job person, one job person, the person existing in the department should be given in job training. They are expected, they ask for the manpower. I think most handsome people sitting there and the chairperson. Can you come here? Sarina Joshi, Mr. Kaviraj Khanna. So Professor Amartya and Professor Rakesh Prasad sent them for the speech therapy assistant. And the Claudia Walter, she trained them to give a speech therapy. So speech therapy started in this way. Claudia Walter was from the Mexico, and now before going to the real theme, the part of the theme I talk about, then I'll again go with the history. Now today we are talking about the multidisciplinary approach. Why? When I came, what was the situation and what is the situation now? Any individual suffering from the communication disorder will not have a single disability or single issue. You may have several issues, and all the issues should be, all the aspects should be covered with. No single person can solve or address all these things effectively. Like a child or adult suffering from the communication disorder may have medical, developmental, educational, social, and emotional. So none of the professionals can solve all these aspects alone. So we need joint collaboration. That's why we need multidisciplinary approach. Now, what they did, that they did the coordinated approach of all the professionals, different professionals, for the holistic assessment. And in the teamwork, who will do what, the role is shared clearly, the responsibility is shared, and the benefit is improved outcomes. We will have better outcomes. So that is good for the integration of the healthcare with the education, with the social and other systems. Now, we are talking about the multidisciplinary approach. Now I am talking about the communication disorder. I don't need to explain what is communication disorder. But if somebody has got only a speech disorder, that too is a communication disorder. If somebody has got language disorder, that too is a communication disorder, or somebody has got hearing problem or cognitive problems. All this comes in combined or single will make the communication disorder possible. What we have to do is we have to do early identification and community-based intervention. You can see these cute kids, all of three of them are having some sort of communication issues. You see the picture, can you identify anyone there? Anybody? No one? Who? Me? Okay. With the big beards in the back. Again, there was a pilot study for the samples survey on deafness. For that, a team of 3 persons, ENT surgeon, numerator, questionnaire administrator, and myself, audiologist, who went to 2 districts of Nepal where we found these 4 kids suffering from communication disorders. This is again easy to recognize. Me giving speech therapy, though it is in the traditional method, sitting in front of mirror and giving therapy. Now it does not exist at all. See how the child is trying to feel the vibro-tactile sensation. So if you have to say communication disorder, if you have to define it, any disorder that affects an individual's ability to comprehend, to apply language and speech, to engage in the dialogues effectively with others, verbally or non-verbally. Disorders can range from simple sound substitution to inability to understand anything, even your native language also. The word communication or word disorder, the 2 words. What do you mean by disorder? So I simply say, if something is not in the order, that is disorder. And communication is not always in terms of speech or what you say, non-verbal or verbal. It can be other things also, other places also we are using it. Like we say, there is no communication between child and parents. Or we say, I cannot communicate with her as she does not understand English. So communication has different. We say telecommunication, mass communication, transportation. Also, there is no good communication from to go here and there. So communication does not mean only the speech or language. Now I'll talk about one story. A 4-year-old boy from very poor family, approximately 15 kilometers from here. A village is here. The child was suffering from low vision, but that was detected later on that child had got low vision. Earlier it was family member had considered the child as a blind, mobility problem, and deafness. Since the beginning, since the birth. So what will be the consequence? No speech development. As I mentioned, she was very poor. No father, single mother. She was poor, single mother, so she had to earn for the bread and butter. So what she used to do is, she used to prepare some food, put inside of the child, in front of the child, and tie the child with a metal chain in some pillar of the house. So that child should not go anywhere. And close the door and go for the whole day to work and to earn the money. So now child was tied like an animal, without a speech, nothing. No one to take care whole day. So the child was passing the motion, everything there only, food is also there only. And again evening she used to come and clean everything and take care. So almost 12 hours a day, the child used to be tied with the metal chain. Now, how we can expect mobility? Now, we few volunteers had program to find out deaf and blind people around us. One of my colleagues, Mr. Madhav Aryal, myself and some other people, we have started visiting village area voluntarily on my own transportation every Saturday. Find out the deaf and blind. But where to go? That information we used to collect from the CPR workers. We have requested all the CPR workers in different areas, if you find any deaf and blind child, please inform us. We'll take care of that. So we got information from a CPR worker that there is a child who is blind also and deaf also. So he doesn't respond to any song. He's already 4 years old now, doesn't have any mobility. All those things he told. Then people went to visit that house. We saw. We didn't know the mother doesn't stay in house. We visited the house and it was locked. So we asked the neighbor to put neighbor. They told yes, child is there inside the house. It is without it locked. Child is there inside the house. Child is tied with the metal chain. So cannot move here and there, cannot crawl. So if you come early in the morning before 7 o'clock, then you can see the child. You can meet with the child. Then again next visit you make, you really found that child is struggling. We felt very, very bad. And then we thought we should take this child to our center. We convinced the mother agreed. We said we'll pay you some money also to take care. We'll take care of your child. We had a NGO called Ankur Foundation for Inclusive Education of the Disabled. I was secretary of that. And we generated fund from our own pocket. And we supported the child. We brought the child to our center, kept the caretaker, and started giving therapy. And then we took the pictures, physiotherapy and speech therapy. We fitted the hearing aid, everything. But that again child was not much improving. Slowly, very slowly. In the meantime, we had a contact with the expatriate occupational therapist. And then we requested her to visit our center. She visited and she told, yes, we can do a lot for this child. She was the one who brought some fund also to care for the 2 years. Not only one child. We hired a hostel for the deaf and blind children. This child had low vision, not blind. So we kept there in our all the food, everything was given from the center. The whole day therapy, physiotherapy, occupational therapy, speech language therapy, psychological, this one, about everything was given from the center. And the child started speaking at the French level. The mother told her what my child, some back. By the time the child became almost 10 years, the child started walking also and speaking at the French level. Everybody became very happy, and we are honored by the whole village for taking care for the child and giving new life to the child. So this is the power of multidisciplinary teamwork. Physiotherapist, speech language therapist, blind educator, and occupational therapist, all together they work well. He is the child, sitting on the chair. And she is the mother. Okay. So you have seen already the power of teamwork. Now, again, this is one of the power of teamwork here. Can you recognize which place, what they are doing, and where? Anybody? No. This is from that ground. Who are all there? ENT doctors, nurses, audiologists, speech therapists. So they are the talk of what? Pulling rope. See, this group, lynch group, not much important. They holding the rope. See the other group position pulling like this. And if you are dedicated, giving your full effort, you are the winner. And they become the winner. See, they become the winner. What is the prize? Bunch of huge banana. If you see in the middle with a yellow balloon, who can recognize? In the middle, yellow balloon, president of the SHANCON. See there. And Mr. Kaviraj Kanal is also from Gujarati, or holding the banana. So they are the winner, they won the banana, now they are enjoying the banana. I want everybody picking. Okay. So now again, we are talking about a little bit about the teamwork. Just now we saw what is the importance of teamwork. Here, from different disciplines, people share their information. If it is multidisciplinary, if it is interdisciplinary, they collaborate, coordinate the goals. And if it is transdisciplinary, so there are shared role. But planning is joint. So there is slightly difference between all these multidisciplinary, interdisciplinary, and transdisciplinary. Okay, now another photo. You can see these two huge persons. She is British expatriate, speech therapist, Tara Winterton. She came as a volunteer to work in our department to help us. She worked for almost 4 years. And her assistant, Mr. Dhanman Guru, speech therapy assistant. So she taught him to give speech therapy. So how many speech therapists you have seen now? Claudia Walter, Tara Winter, two expected. How many Nepali speech therapists you have seen? Ravidas Kanal, Sarina Joshi, and third speech therapist, Dharman Guru. Sorry, even though they were not qualified speech therapists, but in job trained under the supervision of qualified speech therapists, they have a struggle about leadership, and I have enjoyed their struggle. They are the best who made for the speech therapy. So credit go to him also and to her also. Next, when I came back after my completion of my study, when they came and they started all this speech therapy, I was studying in Mysore. After coming back, welcome dinner at their house, I'm enjoying and talking, meeting, for the plan, what to do. Now again, most handsome person you can see here, always young, Mr. Kaviraj Bharat. And before he is now also. Name is Kaviraj. Who is Kaviraj means? A doctor of Ayurveda. He said Kaviraj. He had found some jari booty, which he does not share with others. He is every day, always young and handsome. Good. And next to him, I am sitting there, and both of us was slim lady, Vanessa was born. She is again qualified speech therapist, British BSO volunteers. She worked in our department for 4 years. So they are the one who really helped us to start establishing speech therapy. So they should go to them, not to me. Now, once you are leaving, just take that note and she sent us. Okay, so all this happened between 1987 to 89. Although Vanessa was one came later on, but Claudia Walter and Tara Winter came. We all came between 97 and 1987 and 88 when I was studying in Mysore. But when I returned back in 1989, the whole country had only 6 ENT doctors. Only 6. Now, can you imagine how much? It is over 350. More than 350 ENT doctors. Very few neurologists and speech therapists counting in the figure, maybe 3 or 4 physiotherapists. Actually, only one physiotherapist was qualified from other country, and in the Institute of Medicine they started a diploma course on physiotherapy, and that produced 3 or 4 physiotherapists. So when I came, that time, I think 2 or 3 were already there. There were no occupational therapists. I think I have not heard, I have not met any occupational therapist even in the Mysore. Yes, ISOZO, which is considered as the biggest institute of the Southeast Asia. I have not met any occupational therapist that time. Now maybe there is a plus. So, there were no occupational therapists in Nepal too. Even no clinical psychologist in Nepal. I felt, what should I do? Can I do anything? How to coordinate, how to decide whether I'm going in the wrong way or right way. Suppose if you are driving a car, if you see a straight then chances of making accident is more. But you have to see in the back mirror also, you have to see side mirror also, then okay. If you think whatever I am doing is correct, I should go in my own way, I am the only one person in the country, I am the right one, then it is wrong. You have to take help from the other colleagues also, whether I am going in the right direction or wrong direction. I didn't have anybody from our profession to help. I was alone for a few years. Time is up. Okay. Then I think I take them the back. Main topic I have not come. Anyway, I decided, so I thought it would be very difficult for me. I remember what Dr. Prasad told, that you will have to struggle. But again I thought, no, I should keep the way, path for myself. I should serve my nation. I should not go anywhere. Even though I got offered from different countries. But in the mountainous region of Nepal, taking the path was very difficult. And you know, whatever plant you put, seed you put, accordingly plant will go. So I thought we should put plant, so future will be better. For the especially plant, I mean, especially any field, I seed my work. Okay, so in order to expand the service, I motivated and supported few magnates in my power to study in Mysore. I helped them a lot, pioneer people getting their admission done. And I trained several mathematicians, earbook technicians, and other deaf teachers. Like I'm giving training to the deaf teachers and CPR workers. These are our first batch trained mathematicians. Second, again, earbook mathematicians to people to expand the service in the different setup. Now, as I told you, in order to expand the service in the rural area, we did a sample survey and numerator in the middle. I'm showing the question there, asking the history. See how ENT surgeon is examining. See the background, examining in the village, sitting on the floor, in mud. And he was sitting numerator with the blue windshield helping, holding the child. And myself, after that, doing automatic little bit away in the field. So, multidisciplinary, these are the team who works for the communication disorders and their roles. I did not explain in detail these things. Now, extended team members, sometimes you may need dentists or prosthodontists or neurosurgeons, especially interpreter, radiologists, all these things. In 1999, to register any NGO, we need minimum 7 persons. In 1999, we became 7, especially professional. And we formed an association of especially SHAN. SHAN was established in 1999. But below milestone and lazy founders, it could not grow as much as it should. For first 2 decades, very less work was done by association, impacting this type of conference and other things. But later on, youngsters, they took handover and they improved the SHAN a lot. So we can see the progress here. Now SHAN has reached to the adolescent stage after 26 years of establishment. Now we have about 87, 6 to more than 50, neurologist, neurosurgeon over 140, ASLP from 1 to 120, over 120, physiotherapist, that are only few, Now more than 2,500. Occupational therapist, when they return, that can money, no occupational therapist, now it is approximately 10, and clinical psychologist from 0 to 30. No. So this is the progress. Now what is the challenges in Nepal? Now, awareness, lack of awareness and stigma, it is because of the God, I got curse, I got this type of child and all things, this type of problem, and multi-level, multicultural population, and lack of government policy and advocacy. Now, one more history I'll tell. A 3-year-old child with no speech and normal behavior and mixed several symptoms. I was a bad driver that time. I could not get the support of neurologist. There were no neurologist, no psychologist. I tried my best to improve him, but I could not do much, little bit improvement only also after 2 years of therapy also. I was always considering the child had got minimal brain damage.
Mr. Gurna, sorry to interrupt, but yes, your extra time also is up. Make it fast, please.
Now, I'm going to conclude now. So challenges, there are so many challenges, especially geographical barrier and lack of resources. Now concluding, in order to bridge the gap, whatever the problem is now, we have to increase the manpower, increase the ability of the modern equipment, and both from government level, we have to implement total healthcare system, and communication disorders should be included in the total healthcare system. Now, vision for future is that every child with speech and hearing difficulty should receive the timely intervention, that is early identification, and with they should be managed with the multidisciplinary approach. Now, take home message is we should stop the trend of migrating abroad. We should work in our own country, we should serve our own country, we should give you more satisfaction, practice with honesty and humanity, ethics, that will give again more satisfaction. We should work for Nepal together. We can transform the communication disorder from challenge to opportunity. My decision to struggle and develop the breed in own country became worthy, and the special aid plant has grown up. My dream is fulfilled, and because of that, I got Father of Special Aid too. And followed by again lifetime achievement award and last conference. So if you take pain, pain never goes in pain. That's my big word. Thank you.
Thank you, sir, for handing over your experiences to all the new generations. As the true father of speech and hearing of Nepal, your message generations ahead. Thank you. Thank you so much, Professor Dr. Bimal Kumar Sinha and Mrs. Sharina Joshi for chairing the session, which is sponsored by our gold sponsor, Nepal Hearing and Speech Clinic. Thank you for your generous and collaborative support to our initiative. For this, I'd like to introduce the chairpersons of this session. The chairpersons are Mr. Subhash Chandra Jha and Mr. Jailal Prasad Yadav. Mr. Subhash Chandra Jha is an experienced audiologist with more than 3 decades of expertise in audiology and speech-language pathology. He serves as an audiologist in Tribhuvan University Teaching Hospital, Maharajganj. He is the recipient of Dirgha Seva Padak Long-Term Service Medal from TU and TUTH. He is also the Joint Secretary of Cochlear Implant Group, Nepal. Mr. Jailal Prasad Yadav is Assistant Professor in Audiology, Chitwan Medical College Teaching Hospital, Bharatpur, Chitwan. Mr. J.P. Yadav holds a master's degree in ASLP and has over 9 years of academic and clinical experience. I would like to request both of the chairpersons to kindly begin the session by introducing Nepal Hearing and Speech Symposium. Thank you so much.
We would like to acknowledge our board sponsor, Nepal Hearing and Speech Clinic, serving since 2011-18, located in heart of city Kathmandu, a leading center dedicated to hearing and speech care in Nepal. The clinic has been contributing immensely to improving communication health and professional growth in our field. Now I would like to call Ms. Jasmine Lee, who is a senior audiologist and brand champion, Sonoma, Singapore. Now floor is given to Krishna.
Can you guys hear me clear? Okay, thank you. Very happy to be here today. This is my first time in Nepal. So I will share with you what is the latest product information about our hearing aids, Fauna. Okay, so just now, the first audiologist and speech therapist in Nepal, he shared that multidisciplinary team is very important, and for the child or for the patients with hearing loss to be able to hear what is the first thing that they need for them, which is hearing aids. Okay, so now I will introduce to you, I will share with you some of the latest technology that we have in our hearing instruments. So before we go deep into the detail about innovation, so this is our Phonak history. So Phonak has a very long history in this industry, and in 2008, we led the way with Sound Recover, which is a first frequency compression system. And then we also offer the first adaptive binaural directionality with stereo zoom. Then in 2014, we launched AutoSense OS, setting a new standard for intelligent sound adaptation. Alright, so Phonak is your partner in innovations. We have many years in innovations and AI development. So now let's see what can our hearing aids do for you and our patients. Just a year ago, we launched Infinio, a game-changing innovation that introduced real-time AI technology to the industry. And even right now, after a year, there is nothing comparable in this industry. We received a lot of feedback from hearing aid users, and the feedback was incredible. They even say that this is the clearest hearing aids, clearest sound that I have ever heard. So we are really very proud to share that we sold over 1 million Infinio hearing aids, have been fitted around the world. Okay, so what makes our hearing aid so special? Because Infinio, it incorporates the power of AI to provide real-world benefits in multiple ways. Okay, even though it has become a really huge success, we still listen to the feedback from the end users, and we make Infinio even better based on the different feedbacks that we receive. So we level up our AI performance, make it even faster and easier to use. So now I want to introduce to you our latest innovations, Infinio Ultra, the very best for you. Now let's look how we use AI in Infinio Ultra to offer your clients the hearing, to hear the word more clearly. Okay. Now let's look at how adaptive is our Infinio hearing aids. The research shows that 86% of the clients, they really value the hearing aids that will automatically adapt to the surrounding. And it's very easy to see why. Because our day, it's filled with different kind of environments, for example, with noise or calm situations, or when they listen to music. So they really need technology that really can keep up with their life. So AutoSense OS is at the heart of our Airphonic hearing aids. So it works just like this chameleon. So it uses advanced machine learning AI to identify and adjust automatically to the unique sound environments seamlessly. Okay, and we want to make our AutoSense OS even better to be more precise for our end user. And why classifications is so important? Because the setting in the hearing aids will be different depending on the classifications. Okay, so for example, you can see there's different programs in the hearing instruments. There is comfort in noise, speech in loud noise. So all this, they will have different settings for our end user. So only when the classification is correct, the hearing aid setting is optimized for our client. So thanks to our AI chip, we are able to retrain our chip, train with more real sound recording to make our AutoSense OS more precise, which is 24% more precise compared to our previous generations. Alright, okay. So AutoSense OS is actually scans the environment consistently, analyzing the sound patterns to adjust setting in real time. So we have over 200 combinations of sound settings, which we can deliver a personalized hearing experience to our end user. So the end users are always in the right setting, no matter where they are. Okay, so AutoSense OS improves speech understanding in noise. Okay, ultimately our clients can enjoy exceptionally sound quality for the whole day. With Infinio Ultra, AutoSense OS uses smart speech technology to scan the environments, optimize the setting in real time, so the end user gets clearer speech, better sound with less listening effort. Okay, so now we also Infinio Ultra also improve our also have improvement in our digital tools that will make our clients to be easier to incorporate in their daily life. Let's look at the connectivity part of the hearing instruments. So all of our hearing instruments, Infinio Ultra hearing instruments are powered by the ERA chip. So this is our latest chip. Let us recall what the chip can do for us. So ERA chip in Infinio not just make connectivity stronger and smarter, but it's also ultra responsive. The hearing aids can connect to your phone almost instantly after being switched on, and when they hit the pause button while streaming, the hearing aids will fall back to the automatic program almost immediately, so they will never miss a word. As an audiologist, our role actually, our job scope, our role actually dramatically increased. Last time, maybe you just have to deal with hearing aid, tune the hearing aids, but with the advancement in technology, you need to deal with fitting software, Bluetooth connectivity, and also you have to manage the app for the client. So I believe that somehow you will meet some problems in the clinic involving Bluetooth troubleshooting in the clinic. So this has become an issue, and we have addressed this concern in our latest hearing aids now. So we use standard Bluetooth in our hearing instruments, and now we have improved it. Okay. So we have improved our connectivity in our hearing instruments with one-step pairing. So they just have to connect with the app one time, and they can stream the hearing, the audio to the hearing instruments, and also control the hearing aids with the remote control in the with the app. Okay, it's very easy. The app will direct them the correct way to pair with the hearing instruments. All right. Okay, now with Infinio Ultra, we also have new inventions to make hearing aid maintenance easy for everyone. So actually up to almost 40% of the service appointments is due to earwax issue. Okay, so maybe also in Nepal there will be patients who live remotely. It's very difficult to go to the clinic in the city. So they couldn't change, or they couldn't clean the hearing aids. Maybe they do not have the capability, or they do not have the resources. So when they come back to the clinic after a few months, the hearing aids domes, okay, or the ear molds is filled with earwax. So it actually blocks the sound. It actually blocks the sound transmission to the ear. So to reduce this problem, now we have invented, okay, a new kind of dome, which is our patented EasyGuard vented dome. So this will help in solving the wax management for our patients. Okay, EasyGuard dome features a sealed sound transmitting membrane that protects the hearing aid receivers from earwax. Okay, so they are very easy to clean, helping our clients to enjoy clear sound with fewer interruptions. So they are designed to reduce the service appointment by 38%, saving time in the clinic. Okay, so you can have more time doing counseling or doing other verifications with your patients. So later on during tea break, you can also visit our booth there. We have these domes for you to have some hands-on experience. Okay. So this is the cross-sectional design for the dome, how it looks like with our receivers. So it reduces the need to change the domes, okay? Patients do not have to change the domes so frequently. So it actually reduces the service time, lowers the plastic waste, and makes hearing care more efficient and easier overall. Okay, now let's dive into clearer voice in any directions with our AI technology. So this is another chip in our hearing instrument, which is called the Deep Sonic chip. So this chip is very powerful. It is the industry first AI chip that's built specifically to separate the speech from noise, okay, no matter from which directions. So this chip doesn't just classify the sound scenes, but it also actively processes the sound and instantly pulling speech from the background noise. So this is really a major leap forward in hearing technology. So it is very powerful and fast because it was trained to deliver a very clear speech from any directions, even in a very challenging and noisy environment. So with this, no matter where is the speech coming from, whether it's from the side or from the back, clients can still hear and understand the speech very clearly. So with this deep sonic AI chip, it enables a feature called spared speech clarity in our Infinio Sphere hearing aids. So with this deep sonic chip, it instantly separates speech from noise. Okay, the result is a cleaner and clearer sound than anything seen before. So spared speech clarity is now part of the smart speech technology in our Infinio hearing instruments. Of course, other than that, we also have other features that works together to help our clients to hear better. How roughly it works, okay? So it's powered by the deep neural network. So it tackles one of the number one challenge for our hearing aid user, which is understanding speech in a very loud context. First, it will extract the speech signals from a full environment in real time, and then it enhances that speech against the background noise, and it reintegrates the extracted speech with sharper contrast to improve the speech clarity. So as a result, our clients can now understand speech up to 3 times better in noisy environments, so giving them more freedom to enjoy the conversations, even in a very tough listening environment. And we value in our products a lot, and we prove our products with solid research, because research is one of the key value in Fauna. We want to ensure that all the benefits that our clients receive is well proven. So we have 24 external studies completed with our Infinio hearing instruments. We run the research in 7 research centers spanning across 4 different continents. And we have over 200 plus participants with hearing loss to ensure that our clients know exactly how Infinio Sphere can help them success in the real world. Even though we have received huge success from the field, we continuously do research on our hearing instruments. Okay, so these are the 2 new studies that just recently emerged that shows how much better is spared speech clarity performs in noisy environments compared to the traditional beamformer like our Stereo Zoom 2.0. In these both studies, okay, people understand speech more clearly with lesser effort. Okay, so the first study is done in our research center in Shanghai Innovation Center, and the second research done in University of Oldenburg. Okay, so 2 studies shows a consistent result. Okay, spared speech clarity delivers a level of speech understanding and listening effort improvement than other solutions that cannot match. Okay, so they can understand speech better in noise environment, no matter where the sound is coming from, and the listening effort is reduced. Okay, meaning at the end of the day, they do not feel fatigued or not so tired. Okay, because they do not need to spend a lot of mental effort in order for them to listen and to understand the speech around them in a noisy environment. So the message here is very clear. Spheric speech clarity in our Infinio Ultra hearing instruments offers improvements for our patients that can really help them in their daily life. Okay. So that's how powerful our spheric speech clarity is. And now we have even upgraded our performance to Spheric Speech Clarity 2.0 version. So this Spheric Speech Clarity builds on the original success. We have made our deep neural network more efficient while keeping the same high-level performance that I have just shared for our hearing instruments. So with Spheric Speech Clarity 2.0, we wanted our end user to enjoy the benefits even longer. So making it more efficient, we keep the same great performance, but using less power. So we built a new deep neural network architecture that runs on our Deep Sonic AI chip. So this AI chip now uses 30% lesser power and still delivers the same top performance. Spheric Speech Clarity 2.0 can run continuously up to 11 hours, but we know that almost none of our clients will use it that long. Okay? With Audiosphere, they can get up to 56 hours of battery life in calm situations from just a single charge. So that is about 2 days of usage. So giving them more than enough power for a full day of better hearing. So we want to highlight what's most important for you and your clients. That's why we have all these improvements in our Infinio Ultra platform. Okay, but they are still, even though we have great products, our RIC now, but there are still some feedback or comments from the field that they are asking for a rechargeable ITE. So they are asking where is our Virtual R, which is our rechargeable ITE.
Universal connectivity for your phones. And also clear conversations in a busy environment. Automatically adapting to your different business situations. Customizing your views that you're comfortably all day long use. Experience the new rechargeable data. Powered by ultra-responsive energy and active brainwave technology. For this spring,
So this video is introducing our new Virtual R ITE, which is a rechargeable ITE. Okay. So this new rechargeable ITE offers comfort, connectivity, convenience in one exceptional package. It's coming soon, and you can find it in Nepal Hearing in 2 months' time. So in summary, we are once again pushing the boundaries of what the industry thinks what's possible for AI and what we think is possible for AI. So using the power of AI to deliver real world advancement to our patients' daily life. Okay, so this is the Infinio portfolio as you currently know, but it's getting better. Technology is always progressing, and Infinio Ultra comes with a lot of improvement. So just now I've mentioned about all those advancements that we have, but not to forget, we also have a family of hearing instruments that is specific for our young kids, pediatric solutions, okay? So it's based on 50 years of commitment to the pediatric solutions. We provide the most advanced technology to maximize speech understanding for those little children, okay? So you can see there's a little bit difference for our Sky portfolio, okay? Because it's for children, that's why we have multiple bright colors for them, okay? We even come up with an app that is suitable for those teenagers to use, okay? It's not so complicated, but equipped with all the main features that they need. Just showing here different colors that we offer for our pediatric solutions. Okay, if they need additional, if our clients need additional support in certain situations, for example, very noisy situations, or listening to the TV, or a more challenging situations, okay, the different needs varies client from clients. So have different accessories and smartphone apps that can provide this additional functionality and control for them. Okay, so you can see here what we offer. We have the smartphone app, we have remote control, we have Roger, TV connector, and partner mic. Okay, Roger is our microphone that helps our patients to hear better in a noisy environment or when the speaker is very far. So why this is so important is because our hearing aids is designed to work well within the far field, but what if the speaker is coming from the hearing aids is designed to work in near field distance. But what if our clients, the speaker is coming from the far field distance? So here we'll need Roger microphones to help our clients to hear better. So we have all this demo in our booth outside, so you can come and experience how does it sound later during tea time and lunch time. Okay. And these are some of the Roger microphones that we are providing that can help our clients to listen better in a very challenging, noisy environment. Okay. Okay. So together we can change life. So that's all for my presentations. If you have any questions, so welcome to our booth to know more about our products. Thank you.
Thank you so much. Thank you so much to the speaker for Nepal Hearing and Speech Symposium, and many thanks to the respected chairpersons of the session. I would like to request the chairpersons to receive the token of appreciation from the outside desk. Thank you for chairing the session. Thank you. It's now my distinct honor to transition to one of the most cherished moments of SHANCON 25, the Ganga Godavari Oration Award session. The Ganga Godavari Oration Award is a prestigious recognition instituted by Mr. Sureshwar Lal Karna, the first audiologist and speech-language pathologist of Nepal, in the loving memory of his parents, late Ganga Narayan Das, 1919 to 2001, and late Godavari Devi, 1924 1990. The oration is presented to honor the distinguished professionals of this field. This award embodies a legacy of devotion, scholarship, and service, commemorating the values of dedication, education, and compassion that the founders' parents upheld throughout their lives. To preside over this solemn and celebratory session, may I request everyone to extend a thunderous welcome to our esteemed chairpersons. So I would again like to request Professor Dr. Rakesh Prasad Srivastava, former Dean IIM, Chairman Impact, to chair this session. And Mr. Sureshwar Lal Karna, former Chief Audiologist and Speech Language Pathologist of ASMP Unit DUTH and Father of Speech and Hearing, to chair this session. May I request both the chairpersons to chair this session and take further to this oration award. Thank you so much.
This session of Godavari oration, instituted by none other than Mr. Khan. Our orator is Dr. S.P. Goswami. I'd like to give a brief introduction, very brief because there is no limit to how much I can speak. Mr. S.P. Goswami holds a PhD in speech and hearing, along with PG, DHRM, and even an MBA in healthcare management. He is the first speech and hearing professional to receive the prestigious C.V. Raman Fellowship from the UGC, Government of India, as a visiting scholar at the University of Illinois at Urbana-Champaign, USA. Currently serving as Professor and Dean, Research and Development, Dr. Goswami has over 20 years expertise spans aphasia, aging, neurocognitive communication disorders, and policy development and disability. He has guided multiple PhD scholars, published extensively, and has been recognized with Dr. N. Ratna Award in 2020 for his significant contribution to the field of speech and language pathology. I hope we are going to have a very exciting oration from Dr. Goswami. I please invite him to come to the stage.
Respected dignitaries, distinguished guests, fellow professionals, students, and my guests. Thank you very much for this honor. I wanted to thank the Honorable President, the EC of SHAN, the esteemed dignitaries, ladies and gentlemen. I am deeply grateful to your kind words and for the privilege to deliver this oration. The respect and regard that accompanied this oration are truly humbling and deeply appreciated by me. At the onset, I wish to express my heartfelt gratitude to the members of SHAN, the Executive Council members, the organizing committee members of SHANCON 2025 for bestowing upon me this great honor standing here in this beautiful city of Nepal. I truly feel privileged to deliver this prestigious oration. I understand that Ganga and Godavari oration is held to honor the life and legacy of Sri Sureshwar Lal Karnaji's revered parents. Sri Karnaji is a distinct professional and inspiring true role model for the speech, language and hearing fraternity, respected not only in the country of Nepal but also across India. His humility, dedication and lifelong service to persons with communication disorders have earned him admiration on both sides of border. This oration, instituted in memory of his parents, is a reflection of his true deep gratitude and reverence for his parents. It beautifully symbolizes the value he embodies, graciousness, humility, and the enduring respect one must hold for one's parents, and roots from which we draw strength and purpose. I believe he deserves a standing ovation for reminding us that while gratitude to our parents cannot be measured, it must always be expressed and remembered So ladies and gentlemen, let us give him a standing ovation. Thank you very much. It gives me immense pleasure and due humility to stand before this distinguished audience at the international conference organized by Speech and Hearing Association of Nepal. I bring warm greetings from my colleagues and institutions across border, along with deep admiration for your steadfast commitment to advancing the field of speech language pathology and audiology, and for your dedicated service to persons with communication disorder across this beautiful nation. Gatherings like these are not merely professional events, they are confluence of purpose, much like the sacred rivers that define our geography and our spirit. The Ganga and Godavari, two mighty rivers, flow through the heart of India and shared culture, consciousness of South Asian countries. The Ganga and Godavari river have gracefully flown through the heart of India and Nepal for millennia, nurturing life, culture and spirituality. These sacred rivers course persistence across mountains, plains and fields, nourishing all life around. Their water represents not only life and prosperity, but also the hope, resilience and continuity. In a similar way, communication is flowing current that sustains humans' connection, identity and dignity. For individuals with communication disorders, life often resembles like a rocky area, obstructing this vital flow. Today let us reflect on how a multidisciplinary healthcare approach mirrors these mighty rivers, each with its own unique path, yet united in a mission to bring life, prosperity and empowerment to mankind. They are not just bodies of water, they are living metaphors, which symbolizes the life, the resilience, renewal and interconnectedness. They rise from distinct sources, the icy Himalayas and the sacred Western Ghats, and traverse diverse terrains, nourishing countless communities along the way before merging finally in the sea ocean. And in this sacred flow, they teach us a lesson that strength lies not in isolation, but in confluence, that is in coming together of many streams to serve a great purpose. Just as Ganga and Godavari rise from distinct origins, yet move towards a shared destiny, so to the discipline of speech language pathology and audiology, which is diverse but united in purpose. They remind us true strength is not standing apart but flowing together for what? For flowing together, for what are these rivers if not symbols of variations of calling, movement, connection and renewal? They gather countless streams, each with its own source and story, and transform them into one mighty current of life. And in that confluence lies their grace, their power and their purpose. So too, dear friends, let us look upon our profession. Speech language pathology and audiology is a living rivers that they carry knowledge, empathy and healing through the vast landscape of human experience. In much the same way, communication is vital current that sustains human connection, identity and dignity. Yet just as rivers can remain pure or become polluted, so too our communication. The choice, ladies and gentlemen, rests with us whether we keep our words and intentions clear, compassionate and lifelong, or allow them to be clouded. Let us therefore take a moment to reflect on our communication and on our shared mission to enhance communication for those with communication disorders. And as a result, the rivers are the form of our professions. Friends, our profession, speech language pathology and audiology, are much like the great rivers that shape the civilization. We too flow through the landscape of science and humanity, bridging the world of medicine and education. We touch lives at their most vulnerable moments, when words are falter, when sounds fade, when communication breakdowns, and through this, then we come into life and we help people flow again, making communication a reality for persons with communication disorders. Like the rivers, we draw our strength from many tributaries, ranging from neurology to speech to clinical psychology to special education to science to engineering. We name it, we have it. Thus, the Ganga, vast and embracing, teaches us inclusivity to reach every child, every adult, and every elderly person, regardless of the nature, type, and severity of communication disorders, be a developmental, disordered, or a degenerate. The Godavari and Dakshin Ganga teaches us the adaptability, adjustment, alignment, and the ability to navigate shifting terrains of language, culture, and context, which are the crux for the growth of profession as well as the professionals at large. In our profession too, adaptability, adjustment, accountability is not a choice, but a necessity. No two voices are alike, no two patients are same. Each individual presents a new confluence of biology, environment, and experience, calling for the sensitivity, creativity, and continuous learning for betterment of professionals. At the confluence of Ganga and Godavari, tradition meets transformation. Similarly, at the confluence of our discipline, science meets compassion, research meets clinical practice, and service meets innovation. Just as rivers connect distinct regions and nourish entire civilization, our profession connects discipline, generations, and communities. Bridging the divide between science and service, between evidence and empathy, between human limitations and human potentials. Thus, it becomes essential that strength of our discipline lies in terms of flowing seamlessly together, which we should be in terms of united, purposeful, and ever nourishing the largest stream of human well-being. And as a result, this is nothing but a power of multidisciplinaries. Colleagues, the true strength of our profession lies not in isolation, but in collaborations. As speech language pathologists and audiologists, we seldom work alone, and indeed we should not. Our most meaningful outcome arises when we function as a part of multidisciplinary team, alongside the various medical and other professionals. And each professional contributes a unique perspective, a distinct tributary that enriches the broader rivers of care. Not a single discipline can claim ownership of recovery. It is the confluence of diverse expertise that restores communication, confidence, and connection in persons with communication disorders. Let me share one simple story of a person with aphasia. Okay, the story of a person with aphasia. He was a dedicated bank manager, bank account person, but he met with a road traffic accident. His speech was fragmented, his confidence was shaken, and his professional identity nearly lost. Progress was painful, slow despite consistent therapy, but everything changed when collaboration became the current that carried him forward. The SLPs worked to rebuild his overall communication through structured, evidence-based, and context-driven therapy. Occupational therapy wove these skills into daily routine, transforming therapy into functional and meaningful communications. The neurologist provided medical guidance and monitored the cortical recovery. The social worker offered psychosocial support, vocational counseling, and assistance with disability certification. Soon the rehabilitation process was further enhanced through transcranial direct stimulation, a non-invasive neuromodulation technique to facilitate cortical excitability and neuroplasticity. Gradually, words that have been locked within began to re-emerge. Within months, he spoke again with fluency, purpose, and pride. He regained his confidence, returned to his profession, and most importantly, reclaimed his sense of self, not as a patient, but as a person. That transformation was not the result of one hand or one profession, it was the outcome of many minds, many hearts working in harmony, of science and compassion, converging with purpose. When we work as a team, our effort must resonate like the strings of well-tuned harmonium. Each note is distinct, yet blending into melody that is soothing and meaningful. But let us remember, harmony is beautiful only when the harmonium is tuned properly. Disharmony within a team, however, can never ever create a music worth of listening to. This is the essence of calling the power of multidisciplinary. When diverse disciplines unite under a shared vision, when empathy fuels expertise, even the most disrupted pathways of communication can rediscover their voice, their meaning, and their connections. Let us also remember that communication is no more a luxury, it is the foundation of identity and productivity. Without communication, participation and employment are at risk. With it, lives regain purpose, relationships regain strength, and communities regain inclusion. Ultimately, every word restored, every sound heard, and every conversation rekindled adds not just to rehabilitation, but to rebuild the human potential itself. We also remind ourselves that every professional with multidisciplinary team has a distinct role, responsibility, and strength. Each discipline brings its own perspective and purpose, and together we create a more complete picture of the care. We must understand that on this earth, every living being has enough space, dignity, and identity, provided we are not driven by greed, competition, or ego. Ethical practice is the foundation of professional harmony. When we uphold ethics in our service delivery, we not only honor our patient but also our colleagues. We must learn to respect others for their expertise and in turn earn their respect not through authority or position but through humility, integrity, and skills. The collaboration is born when respect flows both ways. We recognize that our shared goal is not individual glory, it is a collective growth of service of the mankind. And now let us move from the rivers that flow across the earth to the rivers that flow within us, the salient shimmering currents of human brain. If rivers are nature's network of life, the brain is the body grand rivers system, where thoughts, sounds, and sensations travel like the tributaries joining into ocean of consciousness. Just as rivers teach us integration through water, the brain teaches us the integration through the neurons. Even the human brain, our most remarkable organ, embodies the very principle of integration over isolation. Each lobe you can take from frontal lobe to temporal to occipital lobe, they all have a distinct functions. Yet none of these structures function alone. Speech, language, hearing, balance, and swallowing forms the interconnected neural systems which operates across the hemispheres, which communicates through intricates of your white matter pathways such as your arcuate fasciculus, superior longitudinal fasciculus, and corpus callosum. These complex circuits forms a living model of multidisciplinary harmony, each region contributing its expertise, complementing rather than competing, and together enabling a miracle of communication for the quality of life of person with disorders. The same principle guides our profession. Consider the neural network of speech language, your Broca's area plans and consequence speech movements. Wernicke's area interprets your meaning, the adequate fasciculars bridge them seamlessly, and auditory cortex transforms sound into understanding. When one region is damaged, is an aphasia, recovery often depends on the brain's plasticity, where neighboring or contralateral areas reorganize to restore the lost function. This biological resilience mirrors the multidisciplinary teamwork. We strive for clinical practice where each professional supports and compensates for another's limitations while retaining their own identity and expertise. And just in moments of crisis, every part of the brain strives to revive the whole. So too must we as professional community unite our skill and strengthen to restore the communication. Proves that once again that integration, not in isolation, is the true architecture of healing. And yet, colleagues, while brain teaches us perfect integration, the world outside often does not mirror that harmony. If brain is a model of collaboration within the healthcare system around us sometimes struggle to reflect the same unity without. Just as neural pathways can be disrupted by injury, our professional pathways too encounter blockages in policy, in perception and practice. These are not biological but systematic ones created by the gaps in recognition, representation and resources. So, as a mark at the brain's elegance, let us also confront the barriers and challenges our own profession flows. Yet friends, like the rivers that encounter pollution, dams and drought, our profession too has several barriers. We stand today at the defining stage in our professional journey, a stage where our identity and visibility as speech, language and hearing specialists are being tested in terms of economically, socially and institutionally. In many regions, the shortage of trained professionals contribute to limit services accessibility, especially for those in the rural and under-deserved areas. In others, lack of awareness among policymakers, politicians, medical practitioners and public leads to underutilization of our expertise and undervaluing our role in healthcare communication. In most hospitals and medical colleges and clinical establishments, designated position of audiologists and speech pathologists have yet not been created. This omission is not merely a loss for the profession, but it is a profound loss to the patient and to the society. Policymakers and health administrators often fail to recognize that by not creating positions of ASLPs, they may appear to reduce the immediate institutional expenditures. However, in reality, this short-sightedness approach increases the long-term economic and emotional burden on the families, communities, and the nation as a whole. The absence of timely and professional speech-language swallowing, balance and hearing intervention leads to greater dependency, reduced employability, and diminished quality of life, the outcome that ultimately costs the society far from the salary of a qualified speech language pathologist and audiologist. We need a broader and more visionary approach. Shortcuts that compromise essential rehabilitative services are detrimental to national growth and human potential. It must be understood that among various disabilities, persons with communication disorders face particularly low employability, primarily due to the barrier in communication. In today's world, communication is not just a skill, it is a currency of employability, social inclusion, and emotional well-being. By empowering individuals to communicate effectively, ASLPs do not just treat disorders, they transform lives, enhance productivity, and contribute directly to the nation's economic and social progress. Yet our profession has endured challenges, even the forms of abuse. The abuse can be in the form of material, emotional, economical, or psychological. At times, our voices have been overshadowed, our contributors have been overlooked, but we must transform these very challenges into a catalyst, converting every abuse into a use, every obstacle into an opportunity for the betterment of humankind. We must reframe time and again that we are independent professionals, bound not by hierarchy but by purpose, and we are essential members of a team, equal in responsibility, equal in quality, equal in commitment to our patients' well-being. There will always be challenges in interprofessional understanding, in role delineation, and in policy recognition. The rapid rise of artificial intelligence and automated devices brings new ethical and practical questions about how our human skills, empathy, critical thinking, adaptability are to be valued in an increasingly technological world. But let us remember, the rivers do not stop when blocked. They carve their own path, they persist, they adapt, and in that flows lies their strength. But friends, when rivers face obstacles, they do not retreat. They gather strength, find new directions, and carve values that reshape the land itself. Likewise, our challenges must lead us to a reflection, to reform, to research, to the drives of change. For us to overcome barriers, we must first illuminate them with evidence, strengthen them with data, and guide them with policy. The time has come to let our collective knowledge flow beyond our clinics and classrooms to influence, shape decisions, transform communication health from an overlooked service into a national policy. Globally, communication disorders affect estimatedly around 10% of the population, encompassing difficulties in speech, swallowing, and hearing. Nearly 1/3 older adults live with disabling hearing impairment, profoundly influencing the communication, social participation, and overall quality of life. In low and middle income countries, access to qualified professionals and rehabilitation services remains critically limited, leaving vast section of the population without care they deserve. According to WHO, the effective management of communication disorders require early identification, multidisciplinary rehabilitation, and integration of communication health into a national policy framework. Yet, despite the growing body of evidence and international advocacy, implementation often remains lax, not due to the lack of science, but due to the gap between research, policy, and the practice. Regrettably, in many South Asian countries, including India and Nepal, our professionals are not still recognized and are being undervalued. The irony is profound. While we empower individuals with communication disorders to find their voices, we as professionals must also learn to raise our voices clearly, collectively, and confidently, especially before policymakers, legislatures, and shape the future of discipline. But evidence alone cannot move the mountains. It must set in motion by purpose, persistence, and policy. Data, however powerful, becomes meaningful only when it flows beyond research, papers, and conference halls into the lives of those who need it the most. The time has come for us to transform evidence into actions, advocacy into accountability, and policy into practice. For progress like rivers cannot remain confined, it must flow, evolve, and reach every shore of the Nile. Thus, the purpose of our profession is it should be progress. As professionals, our responsibility extends far beyond diagnosis, treatment, and therapy. We must become advocates, educators, and translators of science. It is not enough to generate data. We must ensure that evidence informs policy, that policy drives equitable practice, and that practice continuously enriches our research. Only through this dynamic cycle we can build sustainable and evolving system. Not a stagnant pond of knowledge, but flowing rivers of innovation, collaboration, and compassion that carry our profession forward. Let us remind ourselves that stagnant breeds decay. It leads to mosquitoes and leads to malaria. But movement like a flowing stream brings serenity and growth, and that's what we should also do. We need to flow, we need to evolve. It is just as rivers never stop of flowing, adapting, and nourishing every landscape, nourishing terrains, every land it touches, ultimately finding its own ocean. Our profession too must remain in motion, guided by purpose and resilience. The river teaches us continuity and connection, yet direction is equally vital. And that is where the train becomes, the train represents the discipline of progress. Steady, purposeful, and unwavering. While the river shows us to move with grace, the train reminds us to move with direction. While river shows us to how to move with grace, the train reminds us to move with the direction and with the purpose. Together they teach us our journey as professionals must be both fluid and focused, flowing with compassion, yet driven by commitment toward our destination of service, dignity, and empowerment of all. A train's duty is to move from one destination to another. Passenger board and disembark along the way, each with their own destination and purpose, but train continues steadfastly on its trail. Occasionally, someone may pull the chain, forcing the unscheduled stop. The reason may vary, urgency, emotion, or misunderstanding, but the train does not remain halted indefinitely. Its ultimate purpose is to keep moving towards its destination. Similarly, in our profession, our services to persons with communication disorder must keep progressing. Within a multidisciplinary team, there will be many chain pullers, which can be in the form of emotional, economic, environment, or interpersonal challenges that may attempt to slow us down. There may be moments of confusion, disagreement, or even conflict. Yet, like the train, our mission must remain unwavering to move forward in delivering quality services that enhances not only the quality of life, but life satisfaction, productivity, and identity of persons with communication disorders. Let us take a lesson from the river. Even when dirt is thrown into it, river continues to flow and purify itself. It does not stop. It sustains life. Likewise, as professionals, we must continue to strive with merit, skill, and knowledge, undeterred by criticisms or obstacles. People may speak, system may challenge, but we must keep moving. Without communication, there cannot be a true value to a mankind. I'll just tell you a very small story, just some 2 minutes I'll take. There is a story by one Jugnu. Hindi में I'll tell you. One snake was following a Jugnu. तो वो जुगनू को काटते मतलब he wanted to bite it. तो जुगनू ने सांप को पूछा, भाई मैंने तेरा क्या कर दिया? मैं तेरे से 3 क्वेश्चन पूछ सकता हूँ, मैंने तेरा क्या कर दिया, तू मेरे क्यों पीछे पड़ा हुआ है? कि मैंने तेरा कुछ बुरा किया? कहता नहीं। तेरे को गाली निकाली? नहीं। तेरा मैं फूड हूं नहीं, तो क्या भाई फिर मेरे को क्यों तू मारने की कोशिश में कर रहा है? तो जुगनू ने एक बात बोली कि भाई मुझे ना तेरे से प्रॉब्लम है, मुझे ना तेरे मैं खाऊं या तेरे को नहीं खाऊं उससे प्रॉब्लम है, पर मुझे तेरी चमक से प्रॉब्लम है। लेडीज एंड जेंटलमैन, देयर विल बी पीपल विद इन अस, अमंग प्रोफेशनल्स, जो आपकी चमक से परेशान होंगे। People will bite you, people will put you down, but you should always shine and shine with hardness. That's what the story teaches all of us. So let us be like those jugnus and rivers that flows, and be like the train which moves purposeful, persistent and progressive in nature. Ensuring that our profession, that our service remains in motion toward a destination of dignity, inclusion and empowerment of persons with communication disorders. But let me also offer a word of caution. When we work within a multidisciplinary team, our ultimate goal must be service, not the desire to please everyone. I keep on telling that, okay? Leadership is not about maintaining universal approval. It is about guiding the team along a trajectory of growth and purpose. If, I repeat, listen to this, if your primary aim is to keep everyone happy, then perhaps you belong in a business of selling ice creams. Because ice cream is the only one which can keep everyone happy. But not in the business of service, you might keep certain people unhappy also. So serve with purpose. Make sure that people like you for your work, not like you that they please you, or you just do that maskabazi. That is not what is required. So we must learn to strike the right balance, to be humble, yet assertive, collaborative, yet decisive. True professional lies not in arrogance, but in quiet confidence and clarity of actions. Let us therefore have the courage to call a spade, to speak with honesty, act with integrity, and always keep our compass fixed on what truly matters, that is the welfare of empowerment of persons with communication disorders. And just integrity anchors our actions, learning fuels our journey, for conviction without knowledge is like a river without a source, directionless and dry. To sustain our flow as professionals, we must continually return to the springs that nourish us, that is our education, mentors and our training systems. Friends, no rivers can exist without a source, and our source lies in education and training. The strength of any professional flows from quality of the foundation. Our universities and training institutions must continually evolve, not only to impart clinical expertise, but also to nurture interdisciplinary confidence, cultural competency and ethical sensitivity. The world our students are entering is no longer confined to clinics and classrooms. It is interconnected, data-driven and globally collaborative. We must therefore prepare our students to work across boundaries, to speak the language of medical professionals, to collaborate seamlessly with educators, psychologists, engineers and so on, and also to connect with policymakers to understand data and evidence with scientific rigor, yet practice with empathy and equal strength. They must learn to balance technology with humility, ensuring that while machines may assist, the heart of care remains the humans. Let us also recognize that research thrives not in isolation but in collaboration. Communication disorders do not respect borders, and neither should research. The shared linguistic culture and genetic diversity of South Asia is a unique and fertile grove for collaborative inquiry. By joining hands across our institutions in India, Nepal, Bangladesh, Sri Lanka, and other South Asian countries, we can generate data that not only reaches global science but also strengthen local practice and policies. Together, let us envision a regional network of scholars and clinicians will share our resources, exchange our ideas, and address communication needs of our people. Not as separate nations, but as one scientific and humanitarian community. For just as rivers converge to form ocean, our collective knowledge and compassion must converge to create stronger, more inclusive future for communications. As we strengthen these humans and professional connections, we must also embrace the new current that shape our journey. For today era, the river of knowledge are not fed by geography alone, but by the confidence of innovation and tradition. The same spirit of collaboration that unites our nations must also guide us in uniting the wisdom of our past and the possibilities of future, and this future belongs to your technologies. In today's world, technology is transforming the landscape of communication sciences and disorders, from telepractice and AI-assisted diagnostics to wearable hearing aid technologies. Barrier computer interface and neural modulation therapies are on the way. These innovations are not threats to our profession, they are tributaries that can enrich our shared flow, extending the reach of care to those once beyond our clinical skills. Yet we must remember technology is a tool, not a substitute to the touch. A hearing aid can amplify sound, but only empathy can amplify the meaning. An app can prompt speech, but only a human connection can inspire the voice. A machine can analyze pattern, but only a professional can understand the person. So let us embrace the innovation, but let us remain anchored in our compassion. Let our science be sharp, our technology be advanced, but our hearts or even the human beings should be fair and clear. Thus it is not the devices we design, but the dignity we restore that defines the power of our profession. Beyond every innovation, every algorithm, and every advancement lies the timelessness, human spirit that seeks to connect, to express, and to understand. For in the end, it is the technology that defines us, but our resilience and enduring power of the human mind, spirit, and reclaim the voice of meaning and identity. So when we use this technology, it reminds me of one simple story of it's just a simple story of this story. There was once one donkey was tied. Then one ghost came and opened the donkey. So they released the donkey. So when this donkey was released, he went to the farmer's farmhouse, he spoiled the crops. So the moment the crops were spoiled, the owner of the farmhouse came and killed the donkey. Then the owner of the donkey came to know that my donkey has been killed. He killed the owner of the farmhouse. Later on, his wife killed that owner of the house. So with this way, everyone was killed. So lastly, the farmer asked, what the hell are you have done this ghost? See, the ghost said it, I killed nobody. I just released a donkey that was tied to a rope. It is all of you who released the devil within you, which resulted in everything that happened. So today's social media, like is this ghost. It keeps releasing donkeys on a daily basis, okay? And as a professional, we should not react, argue with each other, that is among the team members, or hurt without knowing the facts, having even a second thought. So it is our responsibility, if not to react to every donkey which is released on this social media. And we should build our professional relationships with our colleagues, with our families, with the human beings. And recently, I was reading today, in India, one donkey has been released with the prefix of doctor. So please be careful in case the donkey gets into Nepal also. So please be careful with that social media also. So ladies and gentlemen, we need to be very careful when we use the technologies. Resilience and identity is the way forward. We are healers of the invisible, not of wounds that eye can see, but of barriers that silence the soul. As a speech language pathologist, we restore what is most fundamental to human existence, the ability to connect, express, and belong. When a child with autism utters their first spontaneous word, when a person with aphasia says, "Thank you very much," after months of therapy, when a child with hearing loss turns in delight to hear his mother's voice. We witness miracles not born of magic, but signs of infused with compassion of teamwork grounded in trust. These are the quiet victories that define who are we. Our professional stands at the confluence of science, art, and service, blending the precision of evidence-based practice and empathy that only the human heart can hear us. Let us not measure our worthy merely by the statistics, the number of patients, what people see, or titles or recognition, but by the voices we help rediscover the confidence, we rebuild and dignity, and we restore them. The true measure of river is not life, but the life it sustains. Likewise, the true measure of our profession is not how visible we are, but in how deeply we touch the lives in homes, classrooms, clinics, communities across the world. Each word we awaken, each sound we restore is a ripple that carries forward, a testament to our resilience, our identity, and an unwavering commitment to human mankind. And as these ripples change, spread outward, they remind us that our individual efforts are streams feeding into a greater current, a current of shared purpose and collective progress. Each of us should act with a care, each movement with empathy, and each spark of innovation flows into something larger than ourselves. For just as every river finds its way to ocean, every contribution we make converges towards a common destination, the world where communication is not a privilege but a universal right. In the conclusion, as we move forward, let us reframe us and share the mission that strength and confluences between disciplines, to bridge the distance between nations, to weave together tradition and innovation, and to serve humanity with humility, excellence, and purpose. In the timeless word of the scripture, there is a famous scripture which is written, Yatra Nadya Samudram Gachanti Tatra Ekatvami Bhavati. As the rivers flow into ocean, they attain unity. Let us, our collective efforts, too flow in the same spirit towards unity in diversity, towards science in service, and towards compassion in practice. May our knowledge inspire progress, our compassion guide our action, and our collaboration sustain our purpose. Like the eternal Ganga and Godavari, let us continue to flow, resilient, inclusive, and ever until every voice is heard, every sound finds meaning, and every life discover connection. For in the end, it is not merely communication that we restore, it's a humanity itself that we help to reconnect through sound and resilience, through science and soul, through every act of listening, understanding, and care. Before I conclude, let me say with this conviction, speech language pathologist and audiology is not only the profession that can both, speech language pathology and audiology is the only and only profession which can create and prevent wars. For every conflict begins with a miscommunication, and every peace is born through understanding. Friends, we may not stand in the borders with weapons, but we stand at the front line of human connection, restoring voices, rebuilding confidence, rekindling hope and prosperity of the world. Let us therefore take a pride in who we are and what we do. For our work is not measured by numbers, but by the quality, compassion, and integrity of our service. Let us continue to speak for those who cannot, listen to those who are unheard, and build a world where communication becomes the bridge to peace, dignity, and inclusion. Dear colleagues, this is not the end. It is the continuum of purpose and passion. For us, sky is not the limit, it is only the beginning. We shall continue to explore every possible sphere in science, in service, and in spirit, but we cannot do it alone. We need the collective strength, wisdom, and contribution each one of us. I express my heartfelt gratitude to all present here today and seek your continued support and commitment to this noble profession. A profession that gives voice to the silence, meaning to the sound, and identity to the lives. Allow me to conclude with few lines that embody the very essential what we do. It's in Hindi. वो सांस किस काम की जिसमें स्वर ना हो, वो स्वर किस काम का जिसमें भाषा न हो, हम वो हैं जो सांस को स्वर और स्वर को भाषा में बदलते हैं. We are the ones who transfer breath into sound and sound into language, the architecture of human connection. Jai Hind, Jai Nepal, Jai Shan, and Jai Isha. Thank you very much.
It's my privilege that I am going to read the oration of my own revered professor, Professor. This speech, so I am going to read the oration, Ganga Godavari Oration Award, Speech and Hearing Association of Nepal, SHAN, Ganga Godavari Oration Award. The certificate of award is proudly presented to Professor Dr. S.P. Goswami, Coordinator, Center for Speech and Language Disorders, and Dean, Research and Development, All India Institute of Speech and Hearing, Mysore, India. Professor Dr. S.P. Goswami, with almost 3 decades of professional experience, is a distinguished academician, researcher, and a visionary leader in the field of speech and hearing in India. He stands as the first Indian speech and hearing professional to receive the prestigious C.V. Raman Fellowship, and is also the recipient of the Dr. N. Ratna Oration Award. He has authored and co-authored over 100 scholarly papers on aphasia and related topics, published in reputed journals, and contributed to 37 books, chapters, monographs, and diagnostic tools. His academic mentorship has guided numerous assessors and has guided masters, doctoral, and postdoctoral scholars. Professor Dr. Goswami is also a member of Board of Examiners in 11 universities, RCI assessor, and external examiner at several institutions, including the Institute of Medicine, Kathmandu, Nepal. His editorial contributions as editor and reviewer of esteemed journals and books, along with the leadership roles as the President of Indian Speech and Hearing Association, Secretary General of the Alzheimer's and Related Dementia Society of India, ARDSI, have further enriched the discipline. Hence, in recognition of his extraordinary leadership, pioneering research, and lifelong dedication to advancing communication sciences, Speech and Hearing Association of Nepal, SHAN, feels proud to honor Professor Dr. Goswami for delivering Ganga Godavari Oration. Now I'd like to request Professor Dr. Bimal Sinha to hand over the token of appreciation to the chairpersons of this session.